Hello, my name is Autumn and I'll be your nurse today. Can I please have your name and date of birth?
Austin Knight, 9/1995.
Alright, perfect. And Mr. Knight, do I have your consent before performing this health assessment?
Yes, ma'am.
Perfect. So first we're going to assess your posterior chest, so I'm going to have you turn around for me. And first thing we're looking at is just assessing the skin, making sure there's no signs of inflammation, redness, any swelling, any abnormal lesions. All of that looks good. Next, we're going to perform to check for the expansion of the lungs. So first, we're just going to press in deep with our thumbs, and then we're going to have the patient take a deep breath. And we can see that the expansions of the lungs were even. Next, we're going to perform the tactile formatus. So we're just going to use the ulnar sides of our hands, and we're going to go down the patient's posterior chest and just have them say 99 every single time that we move. So we say 99.
99, 99, 99, 99.
All right, and then we can tell from that the vibration and the tone is even. Next, we're going to palpate the spinous processes. So we're going to start in the cervical region, and we're just going to count those. So we're going to start at the top, C1, C2, C3, C4, C5, C6, C7. And then next, we're going to move on to the thoracic processes. So we're going to do T1, T2, T3, T4, T5, T6, T7, T8, T9, T11, or T10, T11, T12. And then lastly, we're going to do the lumbar region. So we're going to do L1, L2, L3, L4, and L5. And all those are intact. Next, we're going to percuss over the lung fields and make sure that we listen for sounds of resonance. So we're just going to do that by using our middle finger to percuss. Then all of that is good. Next, we're also going to percuss for diaphragmatic expansion. So for this, we're just going to have the patient take a deep breath and then release it and hold upon releasing. All right, and then we would mark our line there. And then we're going to have the patient take another deep breath and then just hold. And then we would make another line, and then we would measure, and it should be between about 3 to 5 centimeters. And then lastly, we're going to percuss the costovertebral angle. So for this, we're just going to place our hand over the patient's kidney area, and then we'll just percuss. Was that any pain at all?
No.
Okay, so no pain. So if there was any pain or tenderness noted, then it could be signs of inflammation. Now we're going to osculate for breath sounds to just see if there's any abnormal breath sounds. So we're just going to have the patient take a deep breath while we listen with the diaphragm of our stethoscope. And then all that sounds good. Now we're going to have Mr. Knight turn back around and we're going to assess the anterior chest. So same thing as what we did before. We're inspecting for any inflammation, swelling, redness, abnormal lesions. None of that is noted. We can tell that the hair pattern is uniform and all the skin tone looks good. We're also going to palpate for any tenderness or lumps. All that's good. And then we're also going to palpate the same tactile fremitus in the front. So we're just going to have the patient say 99.
99, 99, 99.
All that's good. The tone and vibration is even and equal. And then we're also going to percuss over the anterior lung fields. All that sounds good. And then lastly, we're just going to osculate again the anterior breath sounds. All right, so now we're going to be testing the patient's upper extremities. So first we're going to start with range of motion. So Mr. Knight, first I'm going to have you bring your arms above your head and clasp your hands. Then I'm going to have you bring them down behind your head and then put your hands behind your back. So his range of motion is good. Next we're going to test his strength. So I'm going to have you squeeze my hands. And then I'm going to have you push up on my hand with your forearm. And then try to push my hand down. And then push back and push forward. And we would do this on both sides. And then also while we're doing this, we're just inspecting again the skin for any redness, inflammation, any lesions. Also, while I was palpating, I was assessing his temperature of his skin. All that was good. It was warm. And then now the last thing we're going to do is palpate for his radial, ulnar, and brachial pulse. So we're going to start with his radial pulse. And then we're going to feel his ulnar pulse. And then lastly, we're going to feel for his brachial pulse. That we have our patient in the supine position, we're going to start by assessing his heart. And first we will start with inspection. So we're just inspecting his skin. I don't note any signs of scars of any heart surgeries or any injuries, so all that looks good. Next, we're going to inspect the precordium to make sure there's no heaves at all. So all of that looks good. And then next, we're going to palpate the apical impulse, which is located at the apex of the heart. So all that feels normal. Next, we're going to osculate the apical rate and rhythm. And we would do this using the bell of the stethoscope. And do that for 1 full minute, and all of that sounds good. Next, we're going to osculate the heart sounds. So we're going to start at the aortic area, which is right of the sternum and the second intercostal space. I'm going to do that for 1 full minute. Next, we're going to do the pulmonic area, which is also in the second intercostal space left of the sternum. And then next we're going to do the ERB's point, which is in the third intercostal space left of the sternum. Then we're going to do the tricuspid area, which is left of the sternum in the fourth intercostal space. And then lastly, we're going to do the mitral area, which is in the fifth intercostal space near the midclavicular line left of the sternum. And then all of those sound good. While we have our patient in supine position, I'm going to have him turn on his left side. And I'm going to osculate for any sounds of S3 and S4, which could be indications of a murmur. And we're going to do this with the bell of the stethoscope on the apex. And then all of that sounds good. And then also, while I have the patient turned over, I'm also going to just inspect his sacrum, and I don't know any evidence of pressure ulcers on it. All right, so while I have the patient laying down, I'm going to assume he's in a 45-degree position, and we're going to check for jugular vein distension. So I'm just going to have the patient turn his neck, and I'm going to look at the bottom base of his neck and just inspect for any jugular vein distension. And none is noted, but if it was, then this could indicate fluid. So while we have our patient in the supine position, we're going to go ahead and do an assessment of his abdomen. So first we're going to start with inspection. We're going to make sure there's no redness, inflammation, any abnormal lesions or lacerations, and everything looks good. And then we're going to go ahead and osculate before we palpate, so that way we don't disturb any of the bowel sounds. So now we're going to osculate the bowel sounds, and we're going to start in the right lower quadrant. And then from oscillation, we can tell that the bowel sounds are present. Next, we're going to percuss the liver span. So by this, we would begin in the area that we hear resonance near the lungs, and then we would percuss downward until we hear a dull sound. And then we would mark this spot, and normally it's in the fifth intercostal space. And then once we find that, we would make a mark, and then we would find the abdominal tympani until we move upward. And then we would measure between the distance between the two marks, and normally it's anywhere from 6 to 12 centimeters. So all of that looks good. And then next, we're just going to percuss the liver, and then also over the quadrants of the stomach, and also the spleen. All right, and then all that looks good. We're going to assess the patient with his lower extremities. So first we're just inspecting, making sure that there's no, again, signs of inflammation, redness, swelling. We're also looking at his lower extremities. It looks like his hair pattern is uniform. There's no sign of ankle edema. And we would check each one of his toes for capillary refill, and we can see that his capillary refill of each toe is less than 2 seconds, so that's good. Next, we're going to check the pulses of the lower extremities. So we're going to start with the popliteal, which is behind the knee. And then we would do the posterior tibialis, which is behind the ankle. And then we would also do his dorsalis pedis, which is on the flexor tendon of the toe. And then all those are good and normal. And then lastly, we're going to check the range of motion for his lower extremities. So Mr. Knight, first I'm going to have you pull one of your legs up to your chest and then extend it back out. All right, and that looks good. Next, we're going to have him adduct his leg away from his body and then abduct it back in. All that looks good. We're also going to have him rotate his leg at the hip. That looks good. And then we're going to have him move his ankles side to side. And then have him move his foot up and down. And then we're just going to test the strength also of these motions. So I'm just going to have you push up with your foot, down, and then to the side, and then to the side, and then push your leg up, push it down, to the side, and to the side. So now we're going to test Mr. Knight's neurological assessment. So first we're going to start by testing his sensation. So I'm going to have you close your eyes, and then wherever I touch on you, I want you to tell me, is it a soft object or a sharp object?
Soft. Sharp. Sharp. Soft. Soft. Sharp. Sharp. Soft. Soft. Sharp.
All right, all that's good. Now we're going to get our tuning fork, and I'm just going to hit it on the back of my hand, and it's going to start vibrating, and then I'm going to put the base on Mr. Knight's hand and see if he feels the vibration. Do you feel the vibration?
Yes.
Okay, I'm going to do it on the other hand. Feel the vibration?
Yes.
All right, perfect. And then next we're going to test the stereognosis. So I'm going to have him close his eyes, and I'm going to put an object in his hand, and he's going to tell me what it is.
A TV remote.
All right, perfect. And it is a TV remote. And then also we're going to test by putting his hand in a certain position with his eyes closed and have him tell me what position that his hand is in.
Straight up. To the left. To the right. And down.
All right, all that's good. And then next we're going to check his cerebellar function, and we're going to do this by having him touch his nose to my finger as quickly as he can. All right, and that's good. And then we're also going to test the cerebellar function of his lower extremities, and we're going to do this by having him take his ankle and drag it down the front of each shin. All right, and that looks good. And then also we're going to check the reflexes. We're going to do his biceps, triceps, his brachioradialis, his patellar, and then his Achilles. All right, and all that was responsible. The last thing of our assessment is we're going to do a musculoskeletal assessment, and for this I'm just going to have you stand up, and I want you to walk across the room in your normal walk, just back and forth. All right, and then I want you to walk heel to toe, back and forth. And then on your way back, walk on your tippy toes. And then walk back on your heels. All right, that looks good. Then I'm just gonna have you come here and close your eyes. And I'm just have you stand there, and I'm gonna look at the patient and check for the Romberg sign. And this is just making sure that the patient can maintain his posture while his eyes are closed. And it looks like he can, so that's good. Then I'm gonna have you open your eyes and just hold on to the edge of the table. And I'm going to stand near him for assistant, and I'm going to have him do a one leg bend and go down for each leg. All right, and then that looks good. And then lastly, to finish up, I'm going to have Mr. Knight, I'm going to stand behind him, and I'm just going to have him bend over and touch his toes. And I'm going to assess his spine while he's doing this. So all that is good. It looks very symmetrical. No signs of abnormalities at all, no signs of any deformities in his spine, like scoliosis or anything like that. And then that is all. That completes the health assessment. And thank you, Mr. Knight, for letting me perform that on you.